progress. Congratulations, you're at the finish line. So today we are talking about palliative care. This is Dr. Jessica McFarlin. Probably most of you on day shift have seen her at some point. Our shifts don't intersect as much on night shift, but she does really good work, I can attest. So I'll go ahead and let you take it away, Dr. McFarlin.
All right. So first of all, I want to make this as interactive as possible. So if you're able to, I would love it if you would turn your cameras on just so we can kind of see who we're involved with and make this as interactive as possible because it is 5:15 on a Thursday. And I know most of you guys are probably like me and kind of tired. But as you guys are coming in and getting settled down, let me get my slides up and go on from here. There we go. If you could put one word in the chat box to describe how you are feeling right now. And I'm going to add my word too, as we're getting settled.
Oh my. Okay, I like that one.
I only said hungry because I'm tired too. We got some good sleepy. Okay. Yeah, it's hard. I know 5:15 is hard. And you all have had a lot of lectures kind of in preparation for the new positions that you guys are going to start. So I'm excited for you all for that. Thank you for putting your one word in there. I'm going to turn it over to you all too a little bit later to open it up for some experiences. But we are going to talk about palliative care in the ICU today. Can everybody see my screen? Awesome. So we're going to talk about kind of the role of palliative care in the ICU. And when I say palliative care in the ICU, I'm talking both about the palliative care that you can provide as a nurse or the teams might provide, and then specialty palliative care as well. So please, if you've got I think one of the best ways to teach and learn is through storytelling. So if you've got experiences to share, stories to share, things that you've seen that have been great or things that you've seen that have been not so great, please, kind of raise your hand and we can call on you and ask about that as well. So one of the things before we start talking specifically about palliative care is what do we know about quality care in the ICU? So a lot of research has been looked into this, and J. Randall Curtis, who is this amazing ICU researcher and a palliative care doc as well, has done a lot of interviews with family that talked about what are the signs that you see of really good quality in the ICU. And they developed these 7 domains. And these are things that families feel are valuable. It helps them feel seen. It helps them feel like their loved ones are cared for or patients cared for as well. And those 7 domains of quality care in the ICU are patient and family-centered decision-making, communication, continuity of care, emotional and practical support of patients and families, symptom management and comfort care, spiritual support, and then also emotional and organizational support for ICU clinicians. So making sure if families see that we're supported and work well as teams, that helps them feel supported as well. But those are hard to sort of do every single day. Many of us, when we're doing shift work, whether it's the medical, doctors that are on for 7 days, or you all in nursing that might have 3 shifts in a row, or might not have the patient every day. Some of these are really hard to get. So continuity of care can be hard. And if continuity of care is hard, then communication gets impacted. And then it's harder to support families and make really good decision-making. But those are the things that we really want when we're creating good ICUs and good ICU care. Those are those domains that we really want to focus on is really good quality of care, because those are the ones that are really, really important to patients. And one of the things that we know can help is to sort of bring in these concepts of palliative care into an ICU. And that doesn't just have to be provided by, palliative care doctors and nurses, not specialists, but sometimes patients do need specialist level care. So we know that about 20% of our patients that we care for in the ICU will pass away during that ICU stay. So that's a lot of distress that we all face as folks that work in the ICU. But out of those 20%, less than 5% actually receive subspecialty palliative care in the ICU. And part of that's because a lot of ICUs don't even have access to palliative care. So here at UK, we're pretty lucky because we do, but some ICUs don't. So that's one reason for that. But I really think they can be helpful as we're caring about patients in the ICU or caring for patients in the ICU. So what is palliative care? When you all think about palliative care in the ICU setting, if you could use the chat box and put in there, what are some of the things that you all have seen or you all have experienced? And how do you think about what is palliative care in the ICU? And just put that in the chat box for us. Comfort measures, yeah. Advocate or better end of life and better pain control. Managing the symptoms that come along with illness. Yep, unfortunately, most patients and families equate it with hospice care. Yep, even though that isn't what it is and it limits the possibilities a lot. Yeah, and I would, someone said a helpful transition for the patient and family to whatever the next phase of their care is. Yeah, and then I would add too that sometimes healthcare providers also kind of equate it with hospice, and that could be a barrier as well. But yeah, thank you all for those feedback, and that really does cover a lot of what palliative care specialists do in the ICU. And you all provide a lot of that care too as nurses, right? You all try to be great advocates for your patients, especially if they are facing the end of life. You manage symptoms and stresses that come along with that. You help families think about that transition. So I really think that palliative care is something that we all do. But sometimes you need that specialist to kind of come in when there are unmet needs that the family has. So I try to think about what are those unmet needs that a patient or family has that a palliative care consult might be helpful for. And in addition to being a palliative care doc, I'm also a neuro ICU doctor. So I try to think of it kind of from both lenses. What does the patient need in the situation or their family? So you all define this really well. What is palliative care? Palliative care is focused on providing relief from the symptoms and stress of illness. And the goal is to improve quality of life for both the patient and their family, regardless of prognosis. So regardless of whether or not someone is going to get a cure or get discharged from the ICU. But it's provide relief of symptoms and suffering and improving quality of life for the patient and their family. We think of it as an extra layer of support. When I first got to UK about 7 years ago, palliative care was really kind of new. And we would come to the bedside and people would say, oh, are they going palliative? And I was like, I don't know. Are they going infectious disease? Are they going cardiology? And we don't really hear that anymore, which is awesome because I think, I'm going to see Brian laughing too, because like you probably remember that, like we'd sneak up and that was always the first question I would get asked. And I thought that was funny, but it was because people were so used to asking like, oh, are they going with hospice? So not early in the, 7 years ago, it was kind of new and people didn't understand the difference. So now we don't get asked that nearly as much. And I think that's because in the MICU, you all do a really good job of kind of understanding those differences that palliative care needs exist regardless of how sick the patient is or how they're going to do. Now, certainly it's easy to think of us when patients facing the end of life or facing really high stakes, or maybe we don't know how they're going to do, but we certainly can see people just for extra support for getting through this or for symptoms. So that's really what palliative care is. And I think we're getting better and better all the time at recognizing that. So what are some of the things that we do that add benefits to palliative care? What is that extra layer of support? So one of the things that I like to think that we do in palliative care is we get paid to sit in chairs and talk to people, which is really different from what other people do, right? You all don't have time in the ICU to sit down and really dive deep for a long period of time to talk to families. Now, the cool thing that you all get to do is it's those repeated encounters. So you get to know people in a different way over repeated encounters over and over, which is also really beneficial too. The ICU team, for the most part, is more in and out a couple times during the day, but our team is really there to devote to meetings. And it may not be a formal meeting. It may just be pulling up a chair and asking the family members, how are things going? What have the doctors told you so far? We communicate about future expectations. So we talk a lot about prognosis. Sometimes I don't know the prognosis. Even as a neurointensivist, I don't always know the prognosis. And the longer I do this, the more I realize I have no idea sometimes. But I can talk about best case, worst case, most likely scenario. And for a lot of patients or families, that's really helpful because we can sort of provide a framework around this. And the palliative care team, we try to be experts in prognosis, which a lot of people don't recognize that that is a lot of work that we do is understanding prognosis for different illnesses. We do a lot of symptoms management. So a lot of times people may come in with chronic pain. They may have really hard to control dyspnea. A lot of the folks you take care of are on things like high flow, and we're trying to keep them from being extubated. And we're walking that balance of how do we help their dyspnea as we're getting them through the COPD crisis, but also not get them intubated. So like we can help a lot with symptom management. And then coordination and communication of care plans among all providers. These people come in from all over Kentucky. Oftentimes families aren't at bedside. So we try to really dive deep and get to know what's been going on before they came to the NICU. We try to help with transitions of care. So maybe I'm sure you guys have seen a lot of people that bounce in and out and in and out and in and out of the ICU and the floor. So one of the things we sometimes do is we can be that consistent face as people are transitioning. So getting us, it's not a bad idea if people are getting ready to get discharged from the ICU to step down, but you've got that little like kind of nurse voice that's going off going, this may not be good. Sometimes we can be that helpful transition to when people do bounce back, at least we're kind of a constant face. So there's a whole lot of things that we do in palliative care, some of which are focused on complex medical decision making about the future, but others are focused on just thinking about the here and now. I had a family member this week who one of the ICU attendings was trying to get them to talk with us, and she also equated us with hospice. And when he explained what we did, she said, "Oh, they're not." It was a 17-year-old. It was actually really sad, and his mom said, "Oh, they're not here to talk about the end of his life, but the rest of his life." And I thought that was so beautiful. I thought that was like, yeah, that is like, I want to put that on a coffee mug because that's what we really do. And sometimes it does mean we're talking about end of life, right? I would say more often than not. But it's less focused on the end of life and more focused on how do we provide relationship-centered care that focuses on a real understanding of prognosis and matching up treatments with goals and values of that patient, and then recognizing when we can't meet those goals of that patient. Yeah, I'm going to stop here for a second and just I'm going to stop along the way and kind of get questions from you all as well. What questions do you all have right now about palliative care consults, or what the team might add, or maybe differences between hospice and palliative care, even if they're specific maybe to UK? And y'all can put them in the chat, or you can turn your mics on and ask them.
I have a question about palliative with the MICU. So I know you had that slide that said it's like 1 in 5 patients in America in the ICU get palliative care, but I feel like at UK
1 in 5 die.
Oh, 1 in 5 die, but
Yeah.
only 5% get palliative care.
Yeah.
Do you feel like, at least in the MICU, I feel like we consult palliative care a lot for patients. Do you feel like we're better at it, or we're just like more informed about it that we consult palliative more often, or is it not as often as I'm thinking?
No, I think you're right. I think in the MICU, for the most part, we do get a lot of consults from you all. We look at something at UK called the penetration rate, which means how many out of all the admissions, how many consults do we get for palliative care? And we see our goal is about 7, and we see about 7%, and we see about 5% of all admissions. And I think you're right. I think it's a little higher in the MICU. But I think, yeah, I think the MICU does a really good job of asking for palliative care consults. Are there misses? There are. And one of the things about the MICU is most of the deaths in the hospital actually occur in the MICU. Because of that, I think you all have more experience in doing primary palliative care, meaning some of the patients you all do such a good job at that you don't need to call a palliative care specialist. Or not, maybe, I mean, you do great jobs. Some of the patients, the recognition is there, so the team kicks in and does it without calling the specialist. But I do think that you all are particularly good at using us when needed. Occasionally, it depends on the attending that's on, or maybe the fellow that's on, or the family. But no, I think y'all do. Give props to you all for that.
One thing you'll find about working here, and I know that most of you are relatively new in your nursing careers, but as an academic teaching hospital, we really do lead the edge on a lot of things that I think we take for granted, especially if we started here. And palliative is absolutely one of those things. There's a reason why we get so many transfers from outside hospitals only to withdraw care here. It's because that discussion and that service is not necessarily provided universally.
Yeah. Kentucky gets a C rating for palliative care. And what that means is that has nothing to do with the quality of palliative care. It has to do with how little access there is to palliative care as a state. Now, we could get a D or an F, and we don't. So we get a C, but that doesn't have to do with the quality. It has to do with just lack of access. And we're growing all the time. And at the end of this, I'll talk about what our team looks like. Okay. Any other questions right now? Awesome. I'm going to move on. So when is it okay to call a palliative care consult? How many of you all have ever been taking care of a patient and someone said, maybe during rounds, should we call a palliative care consult? And someone said, no, it's a little too early. I'm going to imagine I can see you all and you're all nodding yes. And that is something that happens sometimes, is sometimes we have this question of like, when do we call? Do we call once we know for certain that this patient is going to do poorly? Do we call once the family is all in agreement? When do we call? I really like this slide that Sandy found that sort of shows what palliative care can look like in the ICU setting. And let me give props, first of all, to Sandy Reagan. Sandy Reagan is our nurse practitioner on our team, one of 3 right now. And this is actually her talk, but she was not able to make it this evening. So I told her I would step in. So I apologize that you're not getting her because she's awesome. And she was a floor nurse at UK for a long time before joining our team. So some of y'all might know her, but in the past, this is kind of a busy slide, but in the past, people used to not get palliative care until like the very end of life. And we know that that's early. Now we know that from the beginning of an illness, people are going to get both disease modifying treatments like chemotherapies and radiation or treatment for their COPD. And at the same time, it's good for them to also get some palliative care. So really good symptom management, really good access to chaplains, nurses, social workers to help live with the disease. And as time goes on and they become more sick, you can see that the amount of palliative care they receive increases, the amount of disease modifying treatment decreases. And then at the very end of life, it's really all palliative care. And what we want to do in the ICU setting is your all's patients are kind of on that border or maybe over the border of being too early or too late. We don't want to wait and see them right when they're like, there's nothing else you can do. If we wait that long, we might have waited too late. But for a lot of patients in the MICU, that's kind of where we are, right? It's crisis communication at that point. And sometimes that might be too late. Now, oftentimes it's not, but we want to avoid that if we can, because we may not have any clinician-patient relationship, right? No relationship between you and the patient, no relationship between our team and the patient, and that can be a real big barrier. Oftentimes there's only minutes to make a decision. We see this a lot, especially in the ER or right before we're ready to intubate. And then the patient's ability to communicate is maybe non-existent. So if we do it too early, then meaning patients are pretty healthy, we might not be able to think too much about the future because sometimes that's hard for patients, but we can start developing good relationships. Patients can still participate. They get a longer time to think about decisions. But we see people in the ICU, we see them kind of here, not quite here, though some are, but sort of here. And I kind of like that in the ICU because it means we can really have a conversation about the serious illness and what's important. It can be a really teachable moment. We have some relationship with patients. You all have gotten to know these patients a little bit, if you've had the chance to take care of them for a few days in a row. There's a little bit more time to make the decision, which is always nice. And patients still might be able to communicate. So this is kind of that sweet spot for when to think about calling palliative care. Now, certainly we'll help all along the way, but we don't want to wait too long, and we don't always want to be too easy. Now, whenever you call, our team's going to figure it out, or try to at least. I don't want to say we'll totally figure it out, but at least we'll be able to go in and say, nope, they're still full code, do everything, and have had a good conversation about it. But finding that sweet spot's important. So when we think about that sweet spot, what are some ways that we can ensure good communication? Oftentimes, we don't have a chance to really sit down and think about what we could do. There's a lot of sort of breaking bad news. So a lot of saying there's nothing we can do, or we need to think about next steps, which sometimes is code for removing life support. And that's fine. Those are, that is totally true. But what we want to do, kind of our skill set in palliative care, and something you all can do as bedside nurses, is really think about what are the empathic communication skills that we can bring to the bedside to help families know that we want to have these conversations based on a building relationship with you, based on showing empathy, expressing empathy for what you're going through, while also thinking about long-term prognosis and patients' goals and values. And I apologize, I'm just returning the page really quick. Okay. So what are ways we do this? And can you all have these conversations? This is from Sandy's slide, and that's one thing I'm always interested in is your all sort of point of view from nurses. What is it like from your all's point of view when you're trying to have these conversations that you're worried about a patient? What are some of the skills that you all pull out or kind of have in your repertoire for working with families that you're worried might have a bad outcome, or maybe there's a mismatch between what we're doing and what you think the patient might want? Do you all have some good stories about how that's gone well for you all, or maybe what you've seen go really well from your all's role, from the nursing role?
Usually I'll ask like if they've ever had like a death in the family or like a similar situation happen.
Yeah. How is that helpful?
You can kind of get an idea of like where they're at with coping and like what their coping mechanisms are. You can also like kind of get a feel for like what's expected. Like if they're not, if they don't have a very good like medical history, I don't know how to word that, like I guess like education
Yeah, like their
related.
healthcare literacy sort of.
Yeah. Yes,
Yeah.
that's the word.
Yeah. We're all tired. Yeah. No, and I love asking that question. I ask that question a lot too. Like, have you ever been in a similar situation? And it helps with healthcare literacy. It helps me sort of titrate how I'm going to approach the conversation. It also gives me some clues about, did they just go through this a year ago with one family member and now they're going through it with another family member? It gives us some idea about, man, is there a lot of trauma associated with this? So yeah, that's a great question. What are some other things you all ask or talk about?
One thing I've personally seen is some of these patients have been chronically ill for a long time, right? Most of these illnesses don't just pop up overnight, and the family's ability to gauge the acuity of illness is usually based on what they can see right there in front of them. So when they are in kind of their final stages, when we encounter them and they're maxed on 4 pressors, but they're either they're so sedated that they're not moving, or they're so encephalopathic that they really can't do anything. To the families, often that looks peaceful. And sometimes they equate that with lower acuity of illness. And they'll think back to, oh, well, he was in the ICU a year ago and he popped back from that. And so it's kind of one of those, you don't want to break their spirit, because hope is a very powerful thing. It's one of the most powerful things. But you also need to gently provide little nuggets of education as you can, maybe not all at once. And that's our advantage of being there 12 hours in a row, is we can do that throughout the shift. We don't have to cram it into one session. And in fact, I encourage us not to do that.
Yeah. Kind of asking them to think about, how is this different? Or you teaching them about how it's different this time around. Yeah. I like saying the phrase, we're in a different place, to sort of let them know, like, yeah, there's something going on.
I was just going to add, I always tried really hard to maintain my relationship as the nurse with the family too, and try not to cross too many boundaries of what I felt like I could share as the nurse versus the physician. And, kind of feeling out those situations can be difficult, but maintaining that relationship I always felt was really important also.
Yeah. And I think you're right. And that's, I think, why Sandy put that question in there, is sort of, as the bedside nurse, how do you balance kind of the information giving, versus like what should come from the attending versus what should come from the bedside nurse versus what should come from the medical student or the resident or the trainee. That's doubly hard when you're working in an academic center, because my goodness gracious, there's like 18 people in the room, at least. I would love to just sit and, how they count and click whether we're washing our hands or not. I want to count and click like how many people come into the room during a day. But yeah, it's hard to balance, like, what is too much. And also, you all are in this unique position, is you can't walk away. You can't sort of like have a tough conversation and be like, I'm just going to get some other nurse to come and cover for me because that didn't go very well. So you all have a lot of things to juggle. And that's another way that we can be helpful too, I think. And I try to encourage my team to always, my team being the palliative care team, to always check in with whoever the nurse is, to say, hey, kind of give me the lay of the land before I walk in there, because you all have started having those conversations or heard families or asked them some of these questions about how they're doing. And that can be really, really helpful. So I think, yeah, you all certainly can have these conversations about goals of care and prognosis, but it's in a different way. The other thing I want to encourage you all to do is, if you do have a palliative care team come for a family meeting, is please see if you can go to that meeting. Like, I think it is so helpful to have the nurse there, because, we'll have these big meetings and maybe make decisions to limit care, maybe not, but you all are the ones that go back to the room that the families come to, 15 minutes later, 30 minutes later, and go, whoa, what was that all about? What did we just do? So it's really nice to partner with you all to help establish that continuity of care, which we know is a really good marker of quality. So what are some of the ways that we have these, what are some of the things we know about having conversations around goals of care, or complex, or I call them complex medical decision making in patients that are really sick? First of all, prognosis is hard. We don't always know how things are going to turn out. Emotions are scary, right? Like, to me, I think about this is a roller coaster. And some people are going to be mad, some people are going to cry, some people are going to be silent. It's hard to interpret all of those. And none of us like conflict. And if we don't have the skills to sort of have these tough conversations about goals of care, that can lead to more conflict. And frankly, no one's really ever taught us how to have these conversations. I used to think that like I knew that as doctors, we didn't get taught how to have these conversations. And I just assumed that like everyone else was taught how to do them, that the case managers, that the bedside nurses, that social workers, that was like what you were taught how to do. And then I had a nurse friend of mine be like, Jessica, we don't none of us really get taught how to do this well. It's kind of part of this hidden curriculum. We each get to get taught how to do it some, but not these really hard conversations. So I'm going to give you some sort of tips for how you might approach this. And if you are looking for some more resources, these are some great sites to look at if you are really interested in thinking about how can I sort of build these really great conversation skills within the bounds of kind of what I can do. So one is vitaltalk.org. That is a website that's got all sorts of tips for good communication. capc.org, man, I encourage, it's free to everyone with a UKY address. Our division pays for it. And I go there, sign up, check it out. They have a whole curriculum on palliative care in the ICU. It's free, it's fun, and you can get nursing credits. So you know how you have to have so many a year? They're free through that, and you can get really great nursing credits. And then HPNA is the Hospice and Palliative Nurses Association. And there are a lot of people that are members of that are not necessarily palliative care nurses per se, but do palliative care every single day. And you all will do palliative care every single day in the ICU. So what are some things that you can do to have these conversations, or what do we do in palliative care that you might notice? So I use this framework to have difficult conversations or goals of care conversations that's called REMAP. And I'm going to kind of break REMAP down. Where is it? Oh, I'm going to break REMAP down as we go. But what it really is it's asking the patient's perspective. Can they reframe and talk about, do they understand what the teams are telling them about how sick they are? And if they can, or if you have to kind of deliver that news about how things are different that Brian was talking about, that's going to come with some emotion. So one of the things that we'll talk about in the next few minutes is how do we attend to that emotion without just saying, let me call you a chaplain. But we do have great chaplains here, so I highly encourage that too. And then after you've attended that emotion, how do you ask the patient what kind of questions they have, or what sort of information might they want to ask their doctors? Because I think someone mentioned that it's hard to know kind of what you can tell someone versus what the doctors can tell someone. However, you can help sort of what we call like prep the patient for, if I were in your shoes, these are some questions I might want to know, to sort of help them prep for what they might ask the patient. And then it's sort of coming up with a plan once they've got that information about how to care for their loved ones. So I always start when I'm doing a palliative care meeting is, would it be okay to talk with you about how things are going? Or, if I'm just introducing somebody, I hear you say you're pretty worried. Would it be okay if we talk about what the future looks like? A lot of times in the MICU, I say, man, you got a lot of doctors and nurses talking to you all the time. Tell me what they've told you so far. Okay. So I just kind of introduced the conversation to make sure that families are okay with talking about it. And y'all have all had families, I'm sure. And if you haven't yet, you will say, I only want good news. Don't come in here bringing me bad news. And that's hard. So, but it also lets me say, oh, sounds like you've gotten some bad news. What worries you? So I kind of use that. So just kind of introducing the conversation. And then I try to see, can families tell me if things are getting worse? Can they reframe it? Can they say, I could tell things are getting worse, or the team came in this morning and told me they're really worried that his kidneys are shutting down. And that means that they're able to explain it a little bit to me. And I'll say something like, given this change, is it an okay time to talk? Or now that we're in a different place, can we think a little bit about what's most important? And if families can do that, they're going to be emotional, right? It's normal for patients and families to have an emotional response when you are starting to talk about tough things. And sometimes they can be cognitive responses too that are really emotions. Is there anything else you can do? It's actually an emotional response. Are you sure you've tried everything? That's really an emotional response. And as doctors, we want to get in and be like, oh no, we've done everything. We've done X, Y, Z, and then we did X again, and then we did Z again. But really just sort of being silent with the patient and saying, I wish there was more, is a better way to respond to that emotion, because oftentimes those questions are actually emotion. So expecting emotion and responding to that can be really helpful. And there's lots of ways that you all can respond to the emotion around this, both during family meetings or when you're in the meetings. And that's really where the empathy comes in. So responding with empathic statements, because we know when patients are sick, their loved ones just naturally are on edge. We go into that fight or flight mode, right? So when we're in fight or flight mode as caregivers or patients, it's hard to calm down if we don't see someone responding to our emotion. So great ways to do that is just to name it. This would really frustrate me too, or I could imagine that you'd be really upset by that. I realize how upsetting this must be. You must be worried about your dad. I love saying, I'm sure you guys, like, y'all know those patients that every time you go in to deliver a medicine, they're like, what medicine is it? And they're writing it down, and who ordered that? What time is it? When's the next dose? And like, that's when you kind of start sweating bullets, because our brain wants to think like, ooh, they're litigious. But really, it's sort of like the only control they can get. So I praise that behavior, and sort of say, like, I can see how much you love your dad because you're taking such good notes, you're asking so good questions. And that helps the patients or the family members see that you see them, that you see what they're doing, and that you know that that's coming from love, and that we're not annoyed by it, even though we might be. It also is a reminder to ourselves of, this isn't about me as the nurse or as the doctor, this is about their care for their loved one. And that reframe can really help decrease moral distress. Um, um, so those are some great ways to respond to emotion. And then questions that I might ask when I'm thinking about goals of care, and I think questions that you all can ask at the bedside too, as you're having these conversations about goals of care, are, given this situation, what's most important to you? And help people sort of think about that. Or what worries you the most about what you all are facing? And kind of keeping track of that. Those are really great things to share with the rest of the healthcare team. They're really great things to share during rounds if you all are doing like team-based rounding. But kind of using that as data, because it helps you know how to take better care of a patient if you can map out what's most important to them. I also do the opposite. Are there things that you want to make sure don't happen to your loved ones? And oftentimes patients will say, well, I want to make sure they don't suffer. Or they might say, no, I want to make sure that, like, people don't limit what they do. I want to make sure that people recognize that even though mom's 80, she was really, really healthy and would want a lot of things. So mapping what's important, that A and the remap, can be really helpful. And then aligning with the patient. So as you're asking these questions to learn what's most important to them or what they don't want to say happen, I might say, as I listen to you, it sounds like the most important things are making sure they're comfortable, giving them enough time to see if they're going to come off the ventilator, but avoiding a tracheostomy. Those are the things that are really important. So, you know, what you do with that information at the moment, you don't have to do anything with it, but it may be worth sharing with the care team if they come around, to let them know that. But those can be really great conversation starters. And then kind of coming up with a plan. So here's what I can do to make sure we address your concerns. Or it sounds like you need more information about prognosis. I'll make sure to ask the attending to come and speak with you. Or I'll make sure to ask, you know, I think the palliative care team would be really helpful. I'll make sure to ask the team if we can order that. So really thinking about, as you're learning these things about the patient, as you're responding with empathy, what are those unmet palliative care needs that you can help address as the nurse? Or, you know, add the attending, or add and ask for a palliative care consult. That could be part of a really good plan. I'm going to go back a few slides. So just to kind of go back to this slide, we covered, you know, remap, which is kind of asking them what they understand, asking permission to give news if you need it, responding with emotion, especially if you've had to deliver bad news, and then managing uncertainty if you don't know about prognosis. If families need more information about prognosis, asking the team if they can specifically ask about that. As you're thinking about these conversations with families that you've had, or when you think about conversations that you might have with families, what are some places that you, as a nurse, feel stuck that we might be able to talk about a little bit, or that you see families feel stuck?
I think, and it's not so much as like families being stuck, it's just more education than anything. We have so many patient families that tell us to do everything without understanding what everything means, not understanding what everything does in the long term. Some of our providers are so good about giving a really clear picture of what everything means, and how, you know, it's not going to do anything, you know, and some of our providers are like, oh, we might as well, it's not going to hurt them to do something. But I think there needs to be more education on how to appropriately teach families and really get them to understand and walk through the process of do everything. Because some of our doctors will really push and will sit with the family and say, I need you to understand, if we do CPR on 92-year-old grandma, grandpa, whoever, I need you to understand that they're going to break all of their ribs. This is going to happen. And I think that's kind of where people struggle and families struggle. You know, we can still treat, but sometimes everything is going to harm and cause pain, especially because so many family members are focused on comfort, but still wanting to do everything, if that makes sense.
Mm-hmm. Yeah. That do everything is tricky. And that is that's one of those spaces where I'll say, like, tell me more about what you're hoping for, you know, and if I'm lucky and they say, well, I just want to get them back home, then I can be like, oh, okay. You know, if they get so sick that we have to do CPR, we're never going to get them back home. And sometimes that helps families, but you're right. Sometimes they need that more of a discussion about why we would cause harm.
We also have a fair number of family members who cognitively completely understand that their loved one would not want the things that are in store for them if we continue aggressive medical treatment, but they feel guilty, or they almost need like a permission, because the person who's sitting with the family member may not be the only one influencing that decision. There could be 15 cousins that aren't there watching, you know, grandpa bleed from his, you know, every orifice, that's saying, oh, well, how could you give up like that? So I think that providing them the permission combined with the education, but still leaving that as their choice can go a long way.
Yeah. Sometimes family needs permission to set limits. Yeah. And I, one of the things I try to teach, the doctor trainees that I'm teaching is one of the things that we can do is give a recommendation. Now, we want that recommendation to be based on what's important to the family. So it's kind of like a math problem. You want to show your work as to why you're making that recommendation. You don't want to just like blithely make a recommendation for someone to be DNR, DNI if you don't know anything about what's important to them. But if you know that what's important to them is restoring health and not letting someone suffer, and also not letting them live in a nursing home in the rest of their life, that might help you make a recommendation to not do CPR because it wouldn't achieve those goals. And if you can show your work like a math problem, that can be really, really helpful, which is where those questions that you all ask at the bedside about what are you worried about, what's most important to you, those little nuggets of data all can help make a recommendation. Because I really do think code status needs to be a recommendation from the medical teams, not like a choice that people get to make. Now, I'm not advocating, that we're too paternalistic, but man, my parents don't know what would be helpful or what's harmful. God love them, but they call me to ask me those questions, and I tell them I am not your doctor, but I think those are hard for all of us to make.
And making that distinction between DNR and do not treat. I think they hear that DNR and think, oh, we're not doing anything. And that's an important talking point too.
Yep, exactly. Yeah. And sometimes the plan, that you might be, we're going to try this for so many days. We're going to do a time limited trial and see if this works, and kind of set up some boundaries and things like that. And it's hard. I mean, having these conversations with families can lead to conflict. But also having these conversations with the doctors can lead to conflict too. I think one of the things that can be really helpful is, I think, here at UK, and I think in most hospitals, palliative care consults can only be requested with the permission of the attending. So the doctors on the team or the nurse practitioner, with permission from the attendings, can call the palliative care consult. And there's a lot of reasons for that. Mostly because it's the same for like infectious disease or pulmonary or whatever. Like, we are a medical team, but there can be conflicts around between what you all see at the bedside and what you hear the family saying or the patient going through and what the medical team says. And certainly if that ever comes up and you feel stuck, just grab one of us and be like, hey, I'm really worried about this. Do you have a way that maybe I could talk to the team about getting a palliative care consult? But I do think, I hope, and I think I've seen that the docs in the MICU really value what's going on at the bedside and what the nurses are seeing. And I think this gets back to what we talked about earlier in the talk, is that the MICU gives us a lot of work, which we're happy for, right? Job security. And that's because if you let them know, like, hey, I think there's some unmet palliative care needs going on here, would you consider a palliative care consult? I think a lot are open to that. And if not on day one, then try again on day two, or ask the family, well, I don't want to get you in trouble, but, but you can be meet resistant sometime, and that's okay. Like we're all just trying to provide the best care for the patient. So, if you're not sure that they're going to be open to it, just, finding a non-judgmental starting point. Can we talk about what the family's saying? Can we talk about what I'm worried about in this patient and why I think a palliative care consult might be helpful, or help me to understand what you've told the family so far, so that I can make sure I understand what the family's hearing, in case there's like a misalignment between what you're seeing and what the rounding doctors are seeing. And then, sort of summing it up with saying, it sounds like we're both interested in the patient's well-being. I'm going to keep checking in on their needs, and we can talk about this in the future if you don't think it's time yet. Um, but it can cause some conflict sometimes, and that's okay. And sometimes, not all conflicts can be resolved. And that goes between you and the family, or our palliative care team and the family, or everybody. It's an intense situation when we're taking care of these people in the MICU. But I think we're all trying to do the best thing for the patient. And my hope is that some of these skills will help resolve some of that moral distress that can happen when you're working in the MICU, because you guys are doing kicktail things every day. You guys are rock star nurses up there in the ICU, taking care of these sickest patients in the state. So thank you for the work that you all are doing and going to start doing. And I hope that we get to know all of you guys as time goes on. And kind of in summary, remember too that you are not alone. Our team definitely wants to help you all do your jobs and provide high quality care. Lean on your internal support, your nurses that are on with you, charge nurses. Develop those friendships. And then the UK has really good chaplaincy. Like, I can't say enough about how great the chaplains are. And part of that is because not only are they there to take care of patients, but they really want to take care of us healthcare providers, whether you're spiritual or religious or agnostic. Like, their role is to help us care for ourselves. So take advantage of that. I think Logan is most likely the daytime chaplain that you guys will see. Remember, communication skills take time. Having these conversations take time. I screw up and say stupid things to patients all the time because we're still learning. Like, I hit walls all the time. Check out those CAPC webinars. They're really, really good and interactive. And we know that adding palliative care does not hurt patients, that it helps patients, that it decreases risk of PTSD, decreases risk of depression, things like that. This is our team. We are interdisciplinary. We have a social worker, we have our own chaplain, we have pharmacists that are rock stars, and then we have an ever-growing number of docs and nurse practitioners and PAs, which is really cool. We also have, oh yeah, there's Matthew. We have a triage nurse every day of the week that can help as well. We are here in person Monday through Friday, 8 to 5. On the weekends, we're here as well, but there's only one of us. So we can't always be everywhere at once. We're a consult service. This is our specific question. So if you might have a palliative question, you don't know how to approach it, Matthew West is our nurse who's always there. And then you can certainly call any of us anytime if you've got a question for us. All right. So we've got a few minutes for questions. I want to really open it up to you guys and see if there's things you want to talk about or insights you want to share with each other. I'm certainly, I'm learning all the time as well.
So I have a question about those families that aren't receptive to palliative care. I've had a couple of patients recently where it's, the horrible family member has stage 4 terminal cancer, oncology signed, everybody signed off. This patient's in agony, but family just keeps refusing and refusing and refusing. Almost to the point where we're not, like, we don't know how to be on the same page. Do you feel like it is still useful to continue reconsulting palliative over and over again in those situations? Or is there like another face that you guys would try to send in? Not, it's not one of those where we're trying to tell this family, like, to give up, but we're like, we want to have someone in here to help control your family member symptoms. Mm-hmm. Has that been an issue before, and how do you guys usually handle that?
So are you talking about, so that's a really good question. Are you talking about patients that we've seen already and sort of said, yeah, we can't really be helpful here, or patients where maybe palliative care has been brought up and they're like, no, I don't want to see them?
Both. I've had patients where, you mention it and they're like, no, we don't want that right now. And then I've had ones where I I'm assuming that maybe our providers, our team didn't tell the family that you guys were getting consulted, and they show up and they're like, no. I've had a couple of patients, this one person that's in and out from Rockcastle, and every admission we try to consult palliative multiple times. The family just says no, 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 no over and over again.
Yeah. I think if it's the first time, I think of it, I try to like frame my brain and tell people like, we're just like the cardiologist, right? If we think someone is in like refractory AFib, we're not going to ask the family, like, is it okay if I call the cardiologist? I need some help. So I put in the chat something that I tell people, like when I'm an ICU doc, because when I'm on in the ICU, I sometimes call palliative care consults because if you're taking care of 12 sick people in an ICU, you don't have time to sit for an hour and have these things. So I kind of have a script that I use, and I'll say, we have a team that helps we have a team that helps with symptoms and complex medical care. They work with us for all patients this sick. We're going to call them to come and meet with you guys. They're called the palliative care team. And that's just it. So I don't really make it a question. I just kind of put that out there. And then, families can always kick us out once we get there. But that's kind of how I do that. For our team, we really discuss most of the patients every day as a team. So when we're doing our table rounds, if it's like someone that we've seen before, there's typically someone on our team, and we'll think through, do we re-engage? I've had some patients where I go, you know what, I don't want the whole team to go, but maybe if our chaplain just starts going and kind of comes in as a neutral party, approaching it more from a spiritual standpoint, they can do a lot of work. Or if there's really specific symptoms, our pharmacist may even go, because all of those team members are trained in having these difficult conversations. So sometimes that's a way in. I think that's a really good situation where you could call our team and say, hey, I'm really stuck here. This family doesn't want to see palliative care or seen them before, and you all signed off, but do you have anything outside of the box that we might be able to add to their care? What else? On that note, I'm going to share one more slide. Can you all see my screen right now?
Oh, yeah.
Yeah. Let me manipulate this. There we go. How about now? Can you see the little QR code? Yeah. So this is a recent student of Sandy Reagan's named Brittany Estridge, and she was doing, I think it was a DNP project. She's a McFarlin nurse, and she this is a podcast that she recorded specifically on using that sort of talking map, that remap, reframing, expecting emotions, mapping the future. She speaks specifically about how to use that in the ICU. So if you like podcasts, if you're like driving to and from work and want to listen to something besides Taylor Swift, that might just be a me thing. That's a good podcast to listen to. So you can check that out. I wanted to give her a shout out for that. All righty. Thank you all so much. And please, when you're around, grab us, say hi, introduce yourselves. And I'm looking forward to working with you all.
Thank you.